Wonderful, Jitendra, wonderful. And I wish that my patients were like yours. That's not my talk, so I wish my talk was like Simmons. Yeah. Okay, we've got 6 minutes, I think, something like that, so I'm not going to give you any reasoning. I'm just going to tell you what I do. And this is schoolboy rugby. It's very humbling to treat these players because you cannot hide from the fact that they will really test you and that there will be recurrences. This is not causing an injury. This is what's considered a good fair tackle, but I just wanted to give you a perspective of the sort of people that we have to deal with. So here in slow motion, so this is considered a good fair tackle. There's no padding. These are just schoolboys. Okay, so what do I do? Basically, what do I think about? Is it a dislocation or subluxation? I agree wholeheartedly with that talk before about has it dislocated or did someone need to put it back in? Multiple dislocations, that really influences me. Goals and timing, do they want to get back to this sort of activity or are they going to be more sedentary? And the examination, hyperlaxity, and whether the patient, of course, has apprehension, any nerve or cuff damage. Now, when we're talking about hyperlaxity, I saw someone before mention the Baton score. We had a look at this, and I looked at the French criteria for shoulder laxity. Does the Baton score correlate with specific measures of shoulder laxity? The answer is no. So look at the shoulder. Imaging, glenoid bony Bankart lesions, bone loss, Hill-Sachs lesions, and of course we want to check the cuff. So imaging, X-ray always, MRI, arthrogram often, and CD with 3D reconstructions sometimes. And when you're considering the surgical procedure, think about the recurrent rates, the complication rates early, the reoperation rates, not always for instability and latter J. What's the plan B if there's a recurrence, and the long-term risks? We don't know some of those to separate them out really, and the quality of life. So this is what I do. First-time dislocator. If we go down on the right-hand side there, low-risk activities, conservative. High-risk activity patient, then I'll evaluate them. MRI arthrogram. If we look at the right hand there, MRI arthrogram, no displaced lesion. They're not hyperlax, this patient. This is a profile of a patient. And they get negative apprehension early. If their shoulder settles early, and there's some evidence behind this, conservative. Okay, MRI arthrogram. If we go to the middle one, Hagel lesion, subscap tear, and also hyperlaxity being another risk factor, open repair. MRI arthrogram on the left, displaced labral lesion, a good labral lesion to fix, apprehensive, not hyperlax, or a bony Bankart lesion which we can fix, arthroscopic stabilization. So just like Hiro Sugaya fixes a bony Bankart that's displaced and rather than replaces the bone, that's what I'll do. Here's an example. 17-year-old rugby player, dislocation tackling, no hyperlaxity, settles quickly, no apprehension early, no displaced labral tear, conservative trial. This guy was a young guy playing at the World Cup rugby for his under-20 age group, and he has a Hagel lesion and a rotator cuff tear. He's had surgery. Okay, what about the MRI arthrogram, then a CT reconstruction if there's concerning bone lesions? So, if we look down on the left, glenoid bone lesion, keep going on the left, good bone fragment, arthroscopic bony Bankart repair. Look down just below on the right of that, glenoid bone loss, for me, more than 15%, ladder J. Okay, how about combined lesions? Sumit mentioned that as well, combined lesions. Large Hill-Sachs lesion, lesser glenoid lesion. For me, arthroscopic Bankart and remplissage. So here's an example, a 23-year-old professional rugby player, recurrent subluxations, no hyperlaxity. He's had an arthroscopic bony Bankart repair. Here's another one, a soldier, recurrent subluxations, arthroscopic bony Bankart repair, including remplissage. Okay, 31-year-old engineer, surfer, adventurer, and with this patient I've gone for a bone procedure, a ladder J. Okay, what about no significant glenoid bone lesions? So I consider the age, activity, risk factors, the number of instability episodes, is it subluxations or truly dislocations, and also does the patient have hyperlaxity. So if we look down on the left there, few instability episodes, not hyperlax, appropriate label lesion for repair, arthroscopic. Down on the right, hyperlaxity, high-risk activities, multiple dislocations, inappropriate label lesion for repair, I'm tending towards Operin. How about recurrences? First recurrence, low-risk patient, conservative trial. High-risk patient, MRI arthrogram, plus or minus CT. If there's no new displaced pathology, conservative trial. And if there isn't, ladder J. Dilemmas, younger patient, high risk with or without surgery. What are your plan Bs? Revision of failed ladder Js. We've talked about other bone augmentation procedures, and also the large bony Bankart with minimal displacement with ongoing symptoms. So, I've already mentioned that the profile often has a 2/3 arthroscopic, 1/3 open, and a proportion of those ladder Js. So you have to choose. There's my French top given to me by my friend Pascal Boileau. There's a hat that's a joke, an American hat, and we have to choose between black and white sometimes, but who knows? Thank you.